Hello, this is Dr. Stanley Kim at Kern Medical. Today, we will discuss sickle cell disease. Sickle cell disease is the most common genetic hemoglobin disorder which causes lifelong pain, anemia, and many organ damages. Treatments are limited, and the life expectancy of sickle cell disease patients are usually 40 years and barely 50 years. It is considered uncurable disease unless patients undergo bone marrow transplantation. But only a minority of sickle cell disease patients can have bone marrow transplantation because of limited genetically matched bone marrow donors. And it's highly toxic. Majority of adult patients cannot tolerate the transplantation. Thanks to the watching. In November 1949, before most of us were born, Dr. Linus Pauling, a Nobel Prize laureate, and his associates published a landmark paper explaining that the sickle cell disease is a molecular disease and is a result of molecular changes of hemoglobin S under oxygen deprivation state. According to a literature, one of his students discovered that sickle cell are only found in the venous blood, not in the arterial blood. So they have an idea already by then. Let's go over the structure of normal hemoglobin A. Red blood cell is basically comprised of many hemoglobins inside and the membrane wrapping and protecting them. Let's zoom in the hemoglobin. Hemoglobin is comprised of two alpha globin chains and two beta globin chains. In the center of each globin is the heme unit. The heme is comprised of protoporphyrin and ferrous iron, the reduced form of iron. And oxygen is attached to the iron molecule. Sickle cell disease is the most common genetic hemoglobin disorder worldwide. It's inherited in an autosomal recessive pattern. It's caused by sickle cell hemoglobin gene, a mutant form of normal hemoglobin A gene. The hemoglobin S genes produce sickle cell hemoglobin, hemoglobin S, and the red blood cells having hemoglobin S may change their shape and become sickle cell in a hypoxic condition. How this can happen? In the DNA of beta globin gene in the chromosome 11, at the codon number 6, the nucleotide base adenine is substituted by thymine, resulting in production of valine instead of glutamic acid. So the hemoglobin having normal glutamine is a hemoglobin A, but the hemoglobin having valine instead of glutamic acid is a mutant hemoglobin S. Please look at this picture. Hemoglobin A has a 2 alpha globin and a 2 beta globin. But the hemoglobin S has a 2 alpha globin and a 2 mutated beta globins in which the glutamic acid was replaced by valine. Some medical students and the residents are confused about sickle cell disease and the sickle cell anemia. The sickle cell disease is a group of sickle cell disorders which include hemoglobin SS disease, which is the sickle cell anemia, and the hemoglobin S beta thalassemia, which is also called sickle thal, and the hemoglobin SC disease and other rare types. The sickle cell SS disease, sickle cell anemia, is a homozygous state. We have two chromosomes, pair of chromosomes, one from father, one from mother. And the patients with this sickle cell anemia, SS disease, have both chromosomes with the hemoglobin S genes. they have severe symptoms. The patients with the hemoglobin S beta thalassemia has one chromosome with hemoglobin S gene inherited from one parent, and the other beta thalassemia genes inherited from the other parent. So it's a compound heterozygous state. There are two types, hemoglobin S beta 0 thalassemia and the hemoglobin S beta plus thalassemia. The patients with hemoglobin S beta 0 thalassemia have no beta globin gene at all, and consequently no hemoglobin A's in their red blood cells. They have severe symptoms like hemoglobin SS. I've seen some hematologists include the sickle beta 0 thalassemia into the sickle cell anemia because they have severe symptoms. And the patients with a hemoglobin S beta plus thalassemia have some remaining beta globin genes, so they have some amount of hemoglobin A's in their red blood cells, and the hemoglobin A deter the hemoglobin S sickling. They have less severe symptoms. The patients with hemoglobin SC disease, their one chromosome has hemoglobin S genes from one parent and the other hemoglobin C genes inherited from the other parents. They have less severe symptoms. But sickle cell trait is a whole lot different. It's a heterozygous state. In other words, one chromosome has a normal hemoglobin A and the other sickle cell genes. So it does not belong to sickle cell disease because people with a sickle cell trait do not have clinical symptoms except very extreme hypoxic conditions. Interestingly, sickle cell trait provides significant protection against malaria, especially dangerous falciparum, by 70 to 90%. Then sickle cell anemia patients like a homozygous SS disease or sickle beta thalassemia will have a protection? No. Actually, their mortality rate is higher when they are infected by malaria. Now the statistics. Sickle cell disease affects about 100 Americans and occurs among 1 out of every 365 African American births and 1 out of 16,000 Hispanic American births. And about 1 in 13 African American babies is born with the sickle cell trait. And the sickle cell disease mortality is decreasing thanks to the vaccination or prophylactic penicillin use. But the average life expectancy is not adequate yet. For publicly insured individuals with the sickle cell disease, the average life expectancy is about 50 years. Male 49 years and the female 55 years. Hemoglobins we have. As we studied, hemoglobin A has 2 alpha globins and 2 beta globins. And hemoglobin A2 have 2 alpha globins and 2 delta globins. And the hemoglobin F, 2 alpha globins and 2 gamma globins. Those 3 hemoglobins are normal. The mutated hemoglobins include hemoglobin S and hemoglobin C. Hemoglobin S has 2 alpha globins and 2 mutated beta globins, and we know at codon number 6 the glutamic acid was replaced by valine. Similarly, in the hemoglobin C, the beta globin at number 6, the glutamic acid is replaced by lysine. What about the beta thalassemia patients? Do they have their own hemoglobins? No. Actually, they have higher level of hemoglobin A2. So when you see high level of hemoglobin A2, you suspect the beta thalassemia. What kind of hemoglobins the sickle cell disease red blood cells have? First of all, let's look at the red blood cells of adults and the children. Look at this picture. Majority of hemoglobins are hemoglobin A, accounting for more than 95%. And there are a little bit of hemoglobin A2, less than 3%, and the hemoglobin F, less than 2%. But when the babies are born, majority of hemoglobins are hemoglobin F, the fetal hemoglobin. The fetal hemoglobin in the fetus inside the mother's womb have advantage of catching oxygens from mother's blood. Mothers give away her oxygens to the baby, signs of love. But after birth, the production of hemoglobin F ceases, and by 6 months, the hemoglobin F is mostly disappears, and then replaced by hemoglobin A. However, in sickle cell anemia, patients have no hemoglobin A because there is no beta globin genes. So all the hemoglobin F are replaced by hemoglobin S. Look at this picture. Hemoglobin S accounts for 85 to 95% in sickle cell anemia. And there are some hemoglobin F, 5 to 15%. Hemoglobin F, as it holds the oxygen, it deters the sickle cell formation. And there are a little bit of hemoglobin A2. Patients with the sickle cell trait have hemoglobin A as their majority hemoglobins, about 60%, and about 40% are hemoglobin S. And the hemoglobin A deters the sickle cell formation, so they don't have symptoms. They have a little bit of hemoglobin A2 and the hemoglobin F. What about the sickle beta thalassemia? In patients with the sickle beta 0 thalassemia, they have no hemoglobin A, we studied in the previous slide. So the majority of hemoglobins are hemoglobin S, accounting for 80 to 90%. And did I mention that beta thalassemia patients have a higher hemoglobin A2 levels? Yes, they have a hemoglobin A2 about 5 to 10%. And they have some hemoglobin F. In patients with the hemoglobin S beta plus thalassemia, they have some hemoglobin A's, maybe about 5 to 15%, but majority of hemoglobins are hemoglobin S, 65 to 90%. And of course, they have a higher level of hemoglobin A2, about 5 to 10%, and a little bit of hemoglobin A2. In patients with the hemoglobin SC disease, as you expect, the half of the hemoglobins are hemoglobin S and the other half hemoglobin C, and a very little bit of hemoglobin A2 and the hemoglobin F. Why did I draw this picture of red blood cells of sickle beta thalassemia and the hemoglobin SC smaller than other normal or sickle cell anemia red blood cells? Because their size of red blood cells are smaller, having lower number of MCV, and they have bullseyes in the center of red blood cells, so-called target cells. So when you see the blood smear of sickle cell disease patient, and you see the sickle cells and the target cells, and the cells are smaller, then you suspect the hemoglobin S beta thalassemia or hemoglobin SC disease. The peripheral smear of my own patients, the sickle cell anemia. There is no sickle cell? Well, these are sickle cells. Not necessarily really sickle. This is the patients having hemoglobin, sickle cell beta plus thalassemia. Don't you see these target cells? And actually, the size of red blood cells are smaller. Can you guess how many hemoglobins in one red blood cells? Think about the population of the US. 300 millions? Yes, pretty close. Each normal red blood cell is packed with 260 million hemoglobin molecules. How many red blood cells we have? Trillions of red blood cells. Then how many hemoglobins we have? Trillions of red blood cells times 260 millions. It's an unimaginable number, like a stars in the galaxy. It's a work of God. Under low oxygen environment, the hemoglobin S loses the oxygen molecules to the tissues and become deoxygenated hemoglobin S. Those deoxygenated hemoglobin S polymerize and become fibers like a rope. This polymerized and the fiber-formed red blood cells twisted and changed the shape to a sickle cell or stick-like cells. And those are rigid and have a high density, which can be separated by centrifuging the blood. In the Kern Medical, we have a plan to do clinical research. By spinning that patient's blood, we separate those sickle cells only from the red blood cells not yet sickled. Then we get rid of these sickle cells and infuse back of the remaining cells back to the patients. We hope this will prevent or treat the acute painful vaso-occlusive crisis events. In order to understand more at the molecular level, we need to study oxygen hemoglobin dissociation curve. When the dissociation curve shifts to the right, the red blood cells lose oxygen. It's not actually losing oxygen, giving away the oxygen to the tissues and cells. But in sickle cell patients, those hemoglobin S, the oxygenated hemoglobin S, polymerized, which changed the shape to sickle cells. But when the oxygen dissociation curve shifts to the left, then the red blood cells catch and hold it inside. They don't give the oxygen away to the cells or tissues. That can deter the sickle cell formation. So when the curve is shifted to the left, the red blood cells hold the oxygen. So the hemoglobin S won't be deoxyhemoglobin S. So it deters the polymerization and the sickle cell formation. If we know the certain condition that can shift the curve to the left, it can be very useful for treatment of sickle cell disease. Yes, the presence of hemoglobin F shift the curve to the left. So the patients with the sickle cell disease with hereditary persistent of fetal hemoglobin have much less severe symptoms. Please remember, this principle is used in gene therapy, which I explain later. As you see, the sickles are dense and rigid, not deformable. So it can clog up the small venules or capillaries, causing tissue ischemia because it cannot circulate well. That's not the only mechanism why the sickle cell patients have vaso-occlusive crisis. Sickle cell also adhere to the p-selectin protein of endothelium. Please look at this picture. The endothelium cells endothelial cells have a P-selectin protein and E-selectin. Especially the sickle cell have P-selectin ligand and binds the P-selectin of the endothelium. So it got stuck. In addition, the P-selectin also capture the red blood cells, which interact with activated platelets, contributing to inflammation, which further interferes the microcirculation. Then the rigid sickle cells and stuck to the endothelium cannot smoothly circulate at the level of small vessels, resulting in vaso-occlusive conditions that cause tissue ischemia, pain, and many other complications. How do you diagnose the sickle cell disease? We used to use the gel hemoglobin electrophoresis, but nowadays most of the laboratory they use HPLC, high performance liquid chromatography, or CE, capillary electrophoresis, because they can provide quantitative analysis and are more sensitive, specific, and less time consuming than hemoglobin electrophoresis. So it's largely replaced the old hemoglobin electrophoresis. Another test I want to mention is hemoglobin solubility test. It's a simple and sensitive specific, can be done very quickly. The principle is hemoglobin S doesn't dissolve in certain solutions, disulfide solutions. So it can be used in emergency room to detect the hemoglobin S quickly, but it does not detect other hemoglobinopathies like hemoglobin C. And also it cannot distinguish sickle cell disease from sickle cell trait. Pathophysiology at molecular level. But now let's move on to the clinical sectors. Patients with the sickle cell disease have a hemolytic anemia and the vaso-occlusive crisis, especially painful crisis, is blocking the microcirculation and have a high risk of infection due to splenic dysfunction and low immunity. The major vaso-occlusive events are stroke, very dangerous, and acute chest syndrome. It also can cause myocardial infarction, congestive failure, and many, actually majority of sickle cell anemia patients have a splenic infarct. And the liver dysfunction, especially iron overload, because of so many blood transfusion in their lifetime. And because of hemolysis, it can cause bilirubin pigment gallstones. And poor circulation and the ischemia and the bone results in avascular necrosis and osteomyelitis. Another dangerous event is multi-organ failure. And also it can cause splenic kidney infarct, hematuria, and the rare medullary renal carcinoma. And the very famous priapism, unwanted erection of the penis, and they can have a skin ulcer, not healed well. Now, anemia. The sickle cell disease is a chronic hemolytic anemia, partially compensated because red blood cell lifespan is about 17 days instead of 120 days of normal red blood cells. So the hemoglobin levels around 8 to 10 gram and have high reticulocytes, 3 to 15%. And you often see the Howell Jolly body. Please look at this picture. Howell Jolly body is a nuclear remnants in the red blood cells, Normally, those red blood cells having Howell-Jolly body are captured and destroyed by macrophage in the spleen. But the patients have a very low splenic function or even asplenism. So those red blood cells having Howell-Jolly body still circulate in the blood that you can see on the microscope. Aplastic crisis. Mostly parvovirus 19 infection can cause aplastic crisis. Hemoglobin drops to 4 or 5, reticulocyte almost 0%. Very dangerous. You need to give blood transfusion. And the splenic sequestration crisis, especially in the children, you don't see in the adults because their spleen is already infarcted or damaged. You see the sudden enlargement of spleen and the high reticulocyte and the sudden drop of hemoglobin by 2 grams from baseline level. Some patients may need to have an emergency splenectomy. Hyperhemolytic crisis, it's rare and we don't know the cause, but some people suspect the concomitant G6PD deficiency. And as a management, patients with acute severe anemia requires blood transfusion. And don't forget folic acid and check for iron deficiency, but many of them have iron overload, so then you have to avoid iron. Hallmark of sickle cell disease is a vaso-occlusive crisis and acute painful episodes. I just want to go over briefly about the general principle in management. Vaso-occlusive pain may begin as early as age 6 months when hemoglobin F disappears and replaced by hemoglobin S, we know. Hemoglobin sickle cell disease pain are mostly managed at home, and the pain is not necessarily correlated with the hemoglobin levels. And the blood transfusion is not indicated in uncomplicated vaso-occlusive crisis pain. Please remember, oxygen not routinely used during uncomplicated pain. Antiplatelet therapy like Efient or Brilinta did not reduce the vaso-occlusive crisis pain event, so you don't use it. And please avoid meferritin, Demerol, because of CNS toxicity can cause seizure or clonus. And the Toradol, we use it very frequently, but in sickle cell painful crisis, it did not show any benefit. It can cause renal toxicity. For inpatient setting, generally non-steroidal anti-inflammatory drugs are not used, but the short course for several days is okay. For renal failure, hydromorphone diluted is safer than morphine because morphines are excreted through the kidney, urine, so the accumulation of metabolites, morphine 6-glucuronide, is accumulated, and then it causes the severe sedation. But diluted, if you use it too much, may increase agitation and hallucination. For all adults inpatients, deep vein thrombosis, venous thrombosis prophylaxis is recommended. Use low molecular weight heparin, but when the kidney function is not good, GFR less than 30, use the unfractionated heparins, because low molecular weight heparin is not indicated for renal failure patient. And avoid cold compression, which may cause constriction and narrowing of the vessels. Warm compression is okay. As a preventive therapy, we used hydroxyurea. If it's not effective or intolerable, there are other drugs or supplement can be used. L-glutamine, Vexelator, crizanlizumab. But crizanlizumab has been taken out of market in Europe very recently. When you discharge the patients, provide enough pain medication and give a follow-up appointment sooner than later. Follow-up appointment within 2 weeks lower the readmission rate. Let's go over American Society of Hematology guidelines for sickle cell pain. For acute pain, the care provider have to make a rapid assessment and administration of pain medication within 1 hour of ER arrival, and the frequent pain assessment every 30 to 6 minutes. And also check for other source of pain, like acute chest syndrome, acute abdomen, like appendicitis, cholecystitis, acute coronary syndrome, myocardial infarction, PE, gout, and avascular necrosis. And the tailored opioid dosing based on consideration of baseline opioid therapy and the prior effective therapy, which actually means individualized care plans. And the short course of non-steroidal anti-inflammatories drugs for 5 to 7 days, in addition to the opioid, may be allowed, but watch for renal function. IV ketamine drip as adjuvant therapy for refractory pain to opioids alone can be used. At Current Medical, we use this IV ketamine with pretty good results. Regional anesthesia for local pain, for example, epidural or peripheral nerve catheter-derived analgesia for localized pain. For chronic pain in adults, for chronic pain due to avascular necrosis, Cymbalta, duloxetine, and the non-steroidal anti-inflammatory drugs can be used, but not for the children. Chronic pain with no identifiable causes, selective norepinephrine reuptake inhibitors like Cymbalta or milnacipran can be used. Also, tricyclic antidepressant, Elavil or gabapentins are helpful. Cognitive behavioral therapy is recommended at very low evidence. Massage acupuncture can be given, which has a very low evidence, but not for acute pain. American Society of Hematology is against the use of corticosteroids because of rebound pain. In the beginning, it subsides the inflammation and pain, but later pain comes back even more severe. But okay for concomitant asthma, then you have to use steroid. And the chronic monthly transfusion therapy to prevent recurrent acute pain is not recommended unless all other measures to control recurrent pain have failed, like hydroxyurea or other disease modifying drugs failed to prevent it. And the chronic opioid therapy for chronic pain is not recommended unless pain is refractory to other modalities. So when it is used, the lowest effective dose is prescribed, and they should not be combined with the benzodiazepine, sedatives, and alcohol. When chronic opioid therapy is used, shared decision-making is essential, and explain the potential harms and the need of monitoring for adverse effects. But when the patients on chronic opioid therapy are functioning poorly and are at high risk of aberrant opioid use or toxicity, then American Society of Hematology suggests against the continuation of chronic opioid therapy. And the American Society of Hematology has no particular opinion, which means no recommendation for or against. For acute pain, some patients have continuous IV morphine drip like opioid infusion and the PCA on-demand dosing, but ASH have no opinion of that. And unscheduled intermittent dosing, round the clock, not by patients asking. And the IV fluid is often used, but indiscriminative IV fluid may not be the great, because many patients with sickle cell anemia or disease have cardiopulmonary deficiencies. But when the patients are dehydrated, then you have to use IV hydration. In case of IV hydration, lactated Ringer solution rather than normal saline is preferred because a study showed that normal saline may induce microvascular obstruction due to alteration of sickle red blood cell biomechanical property. This is not related to ASH recommendation. For chronic pain, chronic monthly blood transfusion therapy for chronic pain may be used or may not be used. Now let's discuss the each vaso-occlusive event. Acute chest syndrome, very dangerous, one of the most common cause of death. The cause is usually infection like a pneumonia, bronchitis in children, but not in the adults. More evidence have emerging that fat embolism is the cause of acute chest syndrome. When patients who died of acute chest syndrome, the autopsy revealed bone marrow necrosis, infarction. So the fat droplets escape the bone marrow through the venous system and go to the chest, lung, and other systemic organs. Clinical manifestations are fever, chest pain, respiratory distress, hypoxia, cough, and wheezing, as well as new pulmonary infiltrates. Without infiltrates, you can't say it's acute chest syndrome. The management include blood transfusion to raise hemoglobin over 9 grams. And in severe case, we do exchange transfusions. And antibiotics should be given usually with azithromycin and ceftriaxones. Azithromycin is good for the mycoplasma. And we give pain medication, bronchodilator, and the incentive spirometry every 2 hours while awake. And the prevention include hydroxyurea, and for recurrent acute chest syndrome, chronic transfusion therapy to keep the hemoglobin S level less than 30% is indicated. Other pulmonary manifestations include asthma, which is more common in sickle cell disease, and the sleep disorder and the nocturnal hypoxia. When the patients have this sleep apnea, treat as a regular sleep apnea. And the pulmonary hypertension is very important complication. It occurs in up to 10% of sickle cell disease patients, and the patients have chronic shortness of breath, chest pain, near syncope, reduced daily activity. Then transthoracic echocardiogram for measurement of tricuspid jet regurgitation velocity is indicated. Those velocity goes up high. Stroke is a dangerous complication occurring in about 25% of patients by age 45 years. Mostly ischemic stroke, but some hemorrhagic strokes in adults. Patients may have a TIAs or silent cerebral infarction. The treatment of choice is exchange blood transfusion. Please remember, can you give TPA, thrombolytic therapy? No, it's not indicated. After a stroke, chronic prophylactic transfusion is indicated to prevent recurrence. And the seizures are more common in sickle cell disease. Due to low immunity from splenic dysfunction and some other mechanism, patients have increased risk of infection. Splenic infarction results in functional asplenism by age 2 to 4 years in sickle cell anemia patients. And they are vulnerable to encapsulated bacteria like a Streptococcus pneumonia, H. influenza. But with the preventive penicillin therapy, infections with other organisms like Mycoplasma, E. coli, Staphylococcus aureus, and especially Salmonella species increase. Hemoglobin SC disease or sickle beta plus thalassemia patients have a less severity of disease than SS disease, in part due to maintaining splenic function during childhood. But the patients with the sickle beta 0 thalassemia have a similar severity. Managements include vaccination, prophylactic penicillin until age 5, but you can still continue the penicillin after age 5. And the fever is a medical emergency. The fever is usually defined by more than 38.5 degrees Celsius, which is 101.5 Fahrenheit. And the empiric antibiotic therapy started within 1 hour, usually ceftriaxone or cipro or levaquin plus minus vancomycin, depending on the suspected organisms. One thing that we need to know is granulocyte colony stimulating factor, filgrastim, like a Neupogen, may increase the risk of acute chest syndrome and multi-organ failure, so we should avoid. The bone complications include dactylitis in children and osteomyelitis, very important, mostly by Salmonella, accounting 70%, and the Staphylococcus aureus, accounting 20% in the US. Imaging study of choice is MRI with a contrast. And if it's suspected and to confirm, CT-guided bone biopsy is necessary. And we use IV Cipro for Salmonella coverage and the vancomycin for Staphylococcus aureus coverage. And ortho consultation for possible debridement is necessary. Septic arthritis is kind of urgent situation, requires urgent joint aspiration, and also need antibiotics, debridement, and irrigation. Avascular necrosis is very important complication occurring in sickle cell disease. It's first reported by Dr. Tanaka at Harvard UCLA, who was my professor and my boss when I was doing a fellowship at Harvard UCLA. Occurring in 10% of sickle cell disease, frequently bilateral, occurring in the weight-bearing bones like the femur heads, most common, the humeral head and distal tibia. The prevalence is highest in sickle SS disease with a concomitant alpha thalassemia, followed by pure SS disease, hemoglobin SC disease. And the hemoglobin F level is protective, as we understand. Osteoporosis also commonly occurs, and the hyperactive, compensatory hyperactive hematopoiesis in bone marrow can result in fish mouth deformity in the vertebra and frontal bossing. And this is the femoral head avascular necrosis. Now, kidney complications. Patients with sickle cell disease often have high GFR. It's due to hyperfiltration and or hypostenuria, which means reduced concentration and the low urinary specific gravities, which results in overestimation of GFR and underestimation of kidney dysfunction. Painless hematuria due to papillary influx are often seen. And they have a high incidence of rare renal medullary carcinoma, usually occurs in Black patients with hemoglobin SC disease or sickle cell trait. Cardiac complications include cardiomyopathy, congestive failure, arrhythmia, and even myocardial infarction and the sudden death. Interestingly, patients with a myocardial infarction, 10% of them have no coronary artery stenosis or atherosclerosis. So myocardial infarction is probably due to myocardial microvascular disease, which may be detected with cardiac MRI, but not by cardiac catheterization. Hemolysis patients have high indirect bilirubin levels, which results in pigment gallstone. For asymptomatic patients, observation may be an option, but sooner or later they will require laparoscopic cholecystectomy. And mostly due to iron overload, patients can develop hepatic dysfunction. Priapism, a prolonged erection of the penis without sexual stimulation, is very important and commonly occurs in about 40% of the patients. In management, the priapism lasting more than 2 to 4 hours is a medical emergency, and often we do an ultrasound to assess the penile blood flow. And the basic CBC reticulocyte, if they have a high WBC count or fever, then need to have a blood culture and antibiotics. For priapism lasting less than 4 hours, usually medical measures are indicated. Hydration, oral analgesics, ice pack, and other measures that have been helpful in the previous episodes. Masturbation and ejaculation may help? No, they don't help. For lasting more than 4 hours, it's a real emergency, and the aspiration of blood from the corpus cavernous without saline irrigation is usually done. And also, urologists inject the alpha-adrenergic agonist, phenylephrine. Prevention includes hydroxyurea and the blood transfusion. The chronic blood transfusion is indicated for recurrent priapism. And the daily PDE5 inhibitors like sildenafil or tadalafil. Multi-organ failure is a life-threatening condition typically occurring in the setting of an acute painful episode. Pathophysiology not fully understood, and this is the condition when immediate exchange transfusion therapy is indicated. We studied that stroke also need to have exchange transfusion therapy. Eye complications include retinal artery occlusion, proliferating retinopathy, more common in the hemoglobin SS and the sickle beta 0 thalassemia, except the proliferation retinopathy is more common in hemoglobin SC disease. Leg ulcer usually occurs in the ankle area and may complicate by infection. Pregnancy increases the vaso-occlusive painful episodes and the acute chest syndrome, occurring more in the third trimester and the 1-week postpartum period. Because the risk of venous and arterial thromboembolism increases, prophylactic anticoagulation is given during hospitalization. And make sure you give additional folic acid, 4 milligrams a day, and consider the prophylactic transfusion for pregnancy complications. Hydroxyurea usually not given during pregnancy and breastfeeding, but during pregnancy it may be used. No evidence of teratogenicity in humans, but it may increase the risk of miscarriage and the low birth weight. Sickle cell trait patients usually do not need a venous thromboembolism prophylaxis, just regard as the normal regular population. The low-dose aspirin is often used from the beginning of the second trimester. Blood transfusion for sickle cell disease is a very important subject. Simple packed red blood cell transfusion is indicated for symptomatic anemia or drop of hemoglobin more than 2 grams from the baseline level, acute chest syndrome, splenic sequestration, aplastic crisis, and hyperhemolysis. Make sure you increase the hemoglobin over 10 grams with a blood transfusion before surgery. But hemoglobin SC disease patients may not need a transfusion for minor elective surgery because their complication rate is lower. But blood transfusion is not indicated for uncomplicated vaso-occlusive crisis pain without symptomatic anemia. And the chronic transfusion therapy is indicated to prevent the recurrent stroke, silent cerebral infarction, acute chest syndrome, priapism, and the pulmonary hypertension. Exchange transfusion is absolutely necessary for stroke because thrombolytic therapy is not used for sickle cell stroke. And for recurring acute chest syndrome and the multi-organ failure, it's important to memorize. To keep in mind, the blood should match RH, C, D, E, and K to minimize alloantibody formation. And the more extensive minor blood type screening may be necessary, but many hospitals do not do this. Pre-storage leukoreduction to decrease febrile non-hemolytic reaction, blood transfusion reaction is recommended. The complication of blood transfusion is alloimmunization and the iron overload. And the chelating therapy is indicated when the ferritin level is over 1500. Some hematologists use it if ferritin level is over 1000 nanogram per ml. Hydroxyurea is the most commonly used disease-modifying therapy approved by FDA in 1998. It reduces painful episodes and improves survival of sickle cell disease patients. The mechanism is to increase the hemoglobin F level by twofolds or more. We have studied the hemoglobin F deters the polymerization and the sickling. Another mechanism is to increase nitrous oxide level. The nitrous oxide is a potent vasodilator, so it helps the circulation. Because the increased hemoglobin F takes about 3-4 weeks and the reduction of painful events are seen in 3 to 6 months, hydroxyurea should be continued for at least 6 months. It's a chemo drug inhibiting DNA synthesis and cell division, but there is no evidence of carcinogenicity. So many hematologists use the hydroxyurea during pregnancy, but not during breastfeeding. But about 20 to 30% do not respond to hydroxyurea. And the hydroxyurea continues during hospitalization or surgery. But again, as I said, it's not used during breastfeeding, and many people still use during pregnancy, although generally we don't use much. L-glutamine, brand name Endari, was approved by FDA in 2017. It reduces sickling and decreases adhesivity to the vascular endothelium, resulting in less acute painful events and acute chest syndrome and fewer hospitalization. The mechanism of action is not clear, but it seems to reduce oxidative stress in red blood cells. It can be used with hydroxyurea. This L-glutamine was developed by Dr. Nihara and Dr. Tanaka at Harvard UCLA. He was the brilliant fellow, a few years after I finished my training there. Sales of Endari are expanding rapidly. Congratulations, Dr. Nihara. Crizanlizumab is approved in 2019, but recently it was taken out of market in Europe and England because the new phase 3 standard trial failed to show benefit, but it's still marketed in the US. Its mechanism is inhibition of P-selectin, which involved in the adhesivity of sickle cells and the white blood cells to the endothelium. Vaxelotor, oxybrita, is approved by FDA in 2019. It inhibits hemoglobin S polymerization and increases hemoglobin level. That's a kind of interesting. It's oral medicine and can be used with hydroxyurea. Allogeneic bone marrow transplantation, also called hematopoietic stem cell transplantation, can cure the sickle cell disease. But only minority of patients can have this treatment because there are not many numbers of genetically matched donors, bone marrow donors. And it's highly toxic. Mortality is about 5%. So as the life expectancy of adult patients is about 50 years, stem cell transplantation is not commonly done in adults. December 2023, the FDA has approved 2 new gene therapies for treatment of sickle cell disease patients who are at age 12 years or older with a recurrent vaso-occlusive crisis. The first one is exa-cel, Casgevy. It's the first gene therapy using CRISPR gene editing technology. We studied that hemoglobin F deters the sickling, but the production of hemoglobin F ceases after birth because of BCL11A genes, which suppresses the hemoglobin F production. So by editing and cutting it, hematopoietic cells can produce hemoglobin F again, even in adulthood. Then the red blood cells will have higher hemoglobin F levels, which inhibits polymerization and the sickling. In clinical trial, over 90% achieved the freedom from vaso-occlusive crisis episodes for 12 consecutive months. It is also indicated in transfusion-dependent thalassemia. But look at the price tag, $3.1 million. I don't know, maybe because of this high price. Recently, the National Institute of Health and Care Excellence in UK announced their draft decision to reject the CRISPR gene therapy exa-cel as a treatment of sickle cell disorder. And the appealing process already has started. The other gene therapy is lovo-cel, Lyfgenia. Instead of using CRISPR gene editing technology, this therapy uses non-violent virus vector, which carries the modified beta globin genes. So the hematopoietic stem cells have this beta globin genes, then these cells produce anti-sickling hemoglobin A genes. In clinical trial, about 90% were free of vaso-occlusive events after treatment for 18 consecutive months. Because 2 patients developed acute myeloid leukemia, there is a black box warning for lifelong monitoring of malignancy. The wholesale price is also over $2 million. How the patients have gene therapy? It's kind of similar to autologous stem cell transplantation. Patients have a stem cell harvest, and these stem cells sent to the laboratory where stem cell genes are edited. And then patients have a chemotherapy, usually using busulfan IV, to wipe out the hemoglobin S hematopoietic stem cells. Then these stem cells with the edited genes are infused back to the patient. And it takes about 4 to 6 months to complete all this process. So grateful that we have wonderful hematology oncology clinic steps. Thank you for watching.